Today we're going to initially start with a brief presentation on breast cancer awareness, what every woman and man needs to know, because how many of us recognize that men also are at risk for breast cancer? Yeah, great. And that is going to be by our wonderful presenter this morning, Dr. Michele Halyard. She is professor of radiology oncology specializing in breast cancer at Mayo Clinic. She is also the dean of Arizona Campus Mayo Clinic. Alex, did I say that right? School of Medicine. She is also one of the founders of the Coalition of Blacks Against Cancer, including the Coalition of Blacks Against Breast Cancer. I remember that from when I first, not too long after joining the Valley, and I came to one of your meetings. It was amazing. I participated for as long as I could. It was a long drive for me. But thank you so much for coming out, and if you could come up and start, we'll get ready. We're also going to have this available on Instagram Live with the Word Church Health Ministry IG account, and also it is being recorded. It's being live streamed also right now, too. For those viewers at home, thank you for joining us.
Thank you, Dr. Gilliam, and thanks, everyone, for being here and for having me. So she said a brief presentation. She gave me 45 minutes, so I'm hopefully not going to talk that long, but we'll have time for questions at the end, but if something's a burning question, please feel free. So I want to start by saying, how many of you have, if you feel comfortable raising your hand, a personal history of breast cancer, that you've had a breast cancer? Okay, we have some survivors, great, and they're thriving too, I can see. How many keep your hands up. How many people have a family member that's had breast cancer? How many people know somebody that's had breast cancer? So just about every hand in the room has gone up, and that shows you that breast cancer is a disease that impacts many of us in our lifetime. And if you haven't known anybody that's had breast cancer to date, you probably will in the future. Next slide. So yearly, there are over 280,000 women who get breast cancer, and 1 in 8 women will develop breast cancer in her lifetime. And as Dr. Gilliam said, breast cancer impacts men too. So the title of my slide about what every man and woman, or every woman and man needs to know, really speaks to the fact that men are not immune to breast cancer either. In Arizona, we have almost 6,000 cases of breast cancer that are diagnosed each year. So I think when many people think of breast cancer or any kind of cancer, they think death, right? That's the first thing that comes to many people's minds. But the good news is that with early diagnosis, over 80% of black women and over 90% of women as a whole are alive and doing well at 5 years with their breast cancer. And so it's important that we all know these facts about breast cancer so that, 1, we can share them with others, and 2, we can be proactive because early diagnosis is the key. Next slide. So black and Hispanic women don't have a higher incidence of breast cancer than white women. That's the good news. And as I said, about 80% of black women or women of color in general are alive at 5 years. And 90% of women who have disease that's just localized to the breast where it hasn't spread are cured of their breast cancer. Death rates are decreasing, and a lot of that has to do with the new treatments that we're developing, research that we're doing, and I'm going to come back to that theme about research at the end. And so it's showing that over time, people are doing better and better with lots of diagnoses of cancers, including breast cancer. And as we can see from, I think, our 4 survivors here, women not only can survive, but they can thrive. Next slide. But the not so good news is that black women tend to have a lower survival rate. And there's a variety of reasons for that. Some of it is later stage diagnosis, less access to high quality treatment, and also biologic factors. We tend to develop a more aggressive type of breast cancer called triple negative, where it tends to be more aggressive. But we have people in this room that have triple negative breast cancer and are doing great and are cured of their cancer. In general, the survival rate is highest amongst white women, kind of slightly less in Hispanic women and less in black women overall. In Native American women, we don't have really good figures about where they fall, but they're kind of somewhere in that range, less than white, but probably not quite as low as black patients. Next slide. Next. Is it moving? It's stuck. So if it's stuck, I've got to get unstuck, right? Okay, I'll give it one quick second. Yes, ma'am. Yep, so the question is, what causes black women to be more advanced? And that is a really good question. So we tend to have a higher grade of disease, which is more biologically aggressive, which we're not entirely sure why that happens. And we tend to develop something called triple negative breast cancer, which is a more aggressive type that starts earlier and has a lower 5-year survival rate. As well, even though the screening is the same between black women and white women, that biology, that factor about how people do is what gives us the lower survival rate. So many people ask, what is cancer, right? So does anybody know? What is it? When they say you have cancer, what is it? What about the cells? Yep, so they don't know when to stop dividing. So in our body, we have many cells that divide orderly. One cell becomes 2 cells become 3 cells. But something happens in the body that triggers an accelerated division. So it means the cells continue to grow and grow and grow. That kind of transformation or the transforming into cancer. And those cells then begin to invade outside of where they started, and then they can invade and spread to other parts of the body. So that's why it's important to really pick out or pick up a cancer early so that we can hopefully cure it before it's spread. So that in this diagram, it shows that you can start off with one cell or a number of cells, and something can occur within the cells, and it can cause them to grow and become cancerous. Next slide. So in breast cancer, I think one of the most important things to realize for all of you is that any cancer is not just one disease. So even when somebody says that they have breast cancer, they can have a variety of there can be a variety of different types that we see in practice that makes one person's cancer different from another person's cancer. The biology or the type of cancer can differ from people. So that's why I always tell people who have a breast cancer diagnosis, when all of their friends are trying to give them advice about what kind of treatment they had and what side effects and all of that, that basically your cancer may be different than someone else's. So on this slide, it shows us a little diagram of the most common type of cancer called invasive ductal. So that little cartoon that shows what the breast looks like on the inside. The breast overlies the ribs. It's largely made up of fat, and particularly the older we get, the more fat there is. And it's made up of milk ducts and milk sacs. And so the most common type of cancer that we see is what's called invasive ductal cancer, where the cancer is involving the duct. So that's down below is a duct that's sliced like a hot dog, and you see those little cells that are pushing outside of the confines of the duct, where it can get into the fatty spaces and can get into lymph glands and bloodstream and travel, although it doesn't always. The next slide will show what a pre-cancer is. So it's what we call a DCIS, or a pre-invasive cancer, and that's a misnomer, right? So there are many women out there who have pre-invasive cancer where those cancer cells have not escaped out of the duct, but they're confined to the duct, so they have no ability to get into vital organs. And we really shouldn't call it cancer because it's a pre-cancer. And so it's important when women are diagnosed to really understand what kind of cancer they have. When someone has a mammogram, and we're going to talk about the importance of mammograms in a minute, when you do a biopsy, we have doctors that look at the tissue under the microscope, and it tells us what kind of cancer you have. And that really kind of starts patients down a trajectory of what kind of treatment they should get. But let's talk about the most important things that women can do to really stay on top of or have early diagnosis. One is breast self-exam. So what does that mean? A woman who still has her breasts need to know what they look and feel like. And what I tell women is to pick a day of the month, and if you're young and you're still having your periods, probably pick it mid-cycle, because a lot of times around the period time, you can get some swelling or cysts in the breast, but kind of pick it mid-cycle. If you're past that season of life where you're not having periods anymore, just pick a date. And the first thing I want you to do is to look in the mirror at your breasts and see what they look like. Now, for some people, their breasts are not symmetric. For some people, they are. For some people, the nipple can be pulled in normally. For other people, it's not. But I want you to, if you haven't been doing this, look what it looks like. So what are you looking for that's abnormal? The first thing you're looking for is, has there been a size change, particularly in one breast or the other? Now, I'm not talking about when we all put on our COVID pounds and our breasts both get larger, and I'm speaking from personal experience, and you can't get into your clothes anymore. I'm not necessarily talking about that. What I am talking about is one breast larger than the other. Does one seem more swollen? Or has there been a size or a color change? Has the breast gotten darker? So there's something called inflammatory breast cancer, where the breast gets redder, and or in brown skin women it gets more purplish color. Or does the skin look different? Does it look like an orange peel? Or is there puckering of this, where the skin retracts in or the nipple retracts in? Anything that is different about the appearance of your skin, you need to investigate. And this goes for men too, right? Because most men, if you're thin, you don't necessarily have a breast that's visible, but you have tissue there. So men need to know what their bodies look like too. So the other thing that you need to do is to really feel what your breasts feel like. Now, many women say to me, my breasts are lumpy, I don't know what they feel like, I don't know what's normal, but it's important to understand what is normal for you, and then if there is a change month to month from one time to the other, then have it investigated. So what are you looking for, and how do you do it? Well, I always recommend that people do their breast exam monthly. Pick a date, again, do it. Two ways. One, you can do it in the shower where you're using soap, and you put soap on the breast, and then feel every different part of the breast and feel lightly and also down to as far down as you can get, because the soap makes it easier for you to pick things up with your fingers. It tends to slide over the breast tissue. Now, how many of you think that a breast cancer always feels like a lump? It may or may not, right? So that's what sometimes people are fooled. It may feel like a lump, or it may feel like a thickening, or sometimes it's a painful area that wasn't painful before. Now, most cancer isn't painful in the breast, but sometimes it can be. Yes, ma'am. No, it's not. So sometimes, she asked the question, is it always visible? So sometimes it is visible, where you can actually see changes on the breast, crusting of the nipple, change in color, retraction or pulling in of the nipple. But other times it's not visible, and that's where we're going to kind of get into the whole mammogram issue. Yes?
Is it more than one kind of cancer that can be at one time, or just one type of cancer?
So the question is it more than one type of cancer that you can see at a time? And people can have more than one type of cancer. Usually, most commonly, you see an invasive with sometimes a background of pre-invasive cancer. But sometimes we see people picked up on mammogram where they have a couple of different spots that are different biologies. That's less common. So could you scroll forward? Scroll. I'll come back to this. Scroll. Okay, let's go back. So you're gonna have to bear with me because this old brain can remember what order my slides are in. So we'll come back to it. So again, knowing what your breasts feel like, knowing that it's not necessarily a lump. It can be a thickening. It could be something that feels. We had a breast cancer patient in our group that said it felt like a Tootsie Roll to her. Other people said we'll say it feels like a thickening. It can be something that's different. The important point is to know what's normal for you, and if something has changed, get it investigated. Now, all of us may have changes in our breasts that we know are normal for us, but if it has changed, please have it evaluated. Yes, ma'am.
I'm a little advanced in age here, so how can we tell the difference in like an aging change as opposed to cancer or anything like
That's
that?
a good question. So how can you tell the difference between an aging change versus something to be concerned about? So generally when we age, our breasts become less dense. They feel more fatty rather than, firmer. And so the key is to really kind of establish your own baseline in your own mind about what is normal for you. And then if you feel something that's different or see something that's different, have it evaluated by your doctor. So, yes.
Some women who get breast cancer get to keep their breasts, and some women who get it don't.
So I'm going to hold that question because that's in that slide deck, and I'm going to show
Okay.
you that. We will get to that somewhere. I don't know where it is now, but we're going to get to it. So, this slide really speaks to what causes breast cancer, and a lot of times we don't know. There are the majority of breast cancers are what we call sporadic. They just happen. I can't tell you how many women say to me, I didn't think I was at risk for breast cancer because nobody in my family had breast cancer. Only 5 to 10% of breast cancers are inherited, or that there's a known family link, a genetic link. So please don't have a false sense of security if nobody in your family has a breast cancer. Okay? Next slide. So there are some risk factors that can cause breast cancer. A risk factor is something that can put you at increased chances of getting breast cancer, but something that isn't necessarily the causative feature of breast cancer. So the highest risk factors are being female and getting older, right? Because most breast cancers occur in your 60s or your 70s. However, we can see breast cancers in women in their 20s, and particularly black women, because that triple negative breast cancer that I talked about tends to occur in younger women. So we see women who develop breast cancers in their 30s, for example. And so we have seen in our group, Coalition of Blacks Against Breast Cancer, which we'll talk about at the end, we've seen women who felt something different in their breast, went to see their doctor, and they said, oh, it's related to your period, or oh, you're really young, and they didn't necessarily investigate. So the take-home message is you've got to be your own advocate, and if something is different, investigate. Did you have a question?
No, I'm just going to do the mic.
Okay. Next slide. So these are the risk factors. So we talked about female, being older, inherited changes in the genes, cause about 5 to 10% of breast cancer. And usually most men who have breast cancer have a genetic component to it. Now, how do you begin to know if you even might have a family gene? What we typically see is multiple members of the family with either breast cancer, ovarian cancer, colon cancer, prostate cancer. Those are the common types of cancers that cluster around a genetic change. So for me, my mom had breast cancer when I was 5. She was 43. Luckily she was early diagnosed. She lived to be 80. She passed away from dementia. But I have a whole series of cousins on my mother's side that have breast cancer. And I just knew I had a BRCA gene. Now, I'm a cancer doctor, and I have been a cancer doctor for 35 years, and it was only a couple years ago I thought, I probably need to check and see if I have my own doctors are the worst, okay? We are absolutely the worst. So I didn't have a known genetic variant, but they had something called a variant of uncertain significance. So sometimes you can actually, if you have a clustering of people in your family and your doctor says you're at high risk, you think that you're at high risk, you can do a test. There may not be a gene that we pick up now, but they keep track of folks. And in the future, sometimes a gene can be picked up. Yes, ma'am.
I've heard where women have gone and they've been genetically tested and they find this gene, and that even though they don't have the cancer, they still have their breast removed.
Yep.
What is the percentage of individuals who do that will never get breast cancer?
Yep, so that's a good question. So if for those of you who know who Angelina Jolie is, right, so married to Brad Pitt and all that, right, so she's probably one of the more famous people in the recent decade that had a bilateral mastectomy where she had both of her breasts removed because her mother had breast and ovarian cancer. She went and got tested, and she had a gene called a BRCA1 gene. In those patients, they have up to an 80 to 90% chance of developing breast cancer, right? And about a 50 to 60% chance of developing ovarian cancer. So for her, by removing her breast, the risk reduction was high. It didn't take her risk down to zero, but it took it down very low. There are other women who have that genetic risk factor and say, I'm just going to wait and see what happens. If I have breast cancer, then I'll deal with it at that time. So some of the other risk factors up there are people with dense breasts. And if your breasts are really dense, that tends to actually increase your risk of breast cancer. And when you have a mammogram, they tell you on the mammogram report your breast density, and they'll tell you if you're at high risk. And they may suggest more vigorous screening. Being overweight, drinking alcohol, first period before 12, being inactive and not breastfeeding can all be increased risk factors. But again, a risk factor doesn't mean it's going to cause the breast cancer. It means that it's just elevated your risk. Let's go to the next slide. Yes?
You listed all those risk factors.
Yeah.
If you have multiple of those risk factors, does that increase the likelihood that you will definitely get breast cancer?
No, it doesn't increase the likelihood that you'll definitely get, but one, it tells you might want to work on modifying those risk factors, which points to this slide of what can you do, but it also reinforces the importance of getting your mammograms and doing your breast exams, right, so that if you do develop something, you can pick it up. But what can you do, right? So some of us, we can feel helpless about, I see all these facts, is there anything I can do? Maintaining a healthy weight. And what does that have to do with it? The more weight that we have, the more estrogen we have floating around in our body, and sometimes estrogen can be a cause of breast cancer. So maintaining a healthy weight is good not only for cutting your breast cancer risk, but also for cutting your cardiovascular or heart risk. Because the number one leading cause of death in black women, in women in general, is heart disease, followed by breast cancer. So maintaining a healthy weight is important. Along with maintaining a healthy weight is eating a good diet. So what does that mean? So a diet that's high in fresh fruits and vegetables, a diet that's high in whole grains, a diet that is low in the kind of bad fats, a diet that's low in eating meat, particularly red meat. Now, I know you're thinking, well, what fun is any of that, right? But I think that there are ways to prepare foods that are healthy, nutritious, and tasty compared to the way that we sometimes like to eat. Now, do I like my fried chicken at times? Yes, I do. Do I eat my steak at times? Yes, I do. But so it doesn't mean that it has to be all or nothing, but you really do need to be cognizant of what you're eating, reducing processed meats and processed foods. All of those things can help your health overall. Adding exercise to your routine is important. We know that for women who have breast cancer, getting at least 3 hours of exercise per week, kind of moderate exercise, cuts your risk, but exercise can also keep your weight in a good range. So what is that? What does that like to be? What do you all like to do to exercise? Kickbox, okay. Okay, what else? Walking, okay. Biking, mm-hmm. Did somebody say fencing? Oh, I thought I heard fencing. I was like, ooh, I'm scared of you. Dancing, yes, dancing, right? So anything that gets your heart rate up. So a lot of times people think of exercise, oh, I got to join a gym, I got to get on a treadmill. The most important thing is to do the things that you like to do to keep you going. So limiting alcohol intake is important. It helps not only with limiting your breast cancer risk, but also decreasing your overall risk of heart disease as well. You're in a low power mode, Dr. Gilliam. Limiting postmenopausal hormone use. So some women have taken hormone therapy for menopausal symptoms, to treat hot flashes, to do a lot of things that, when you lose your hormones, are not sometimes the best for quality of life. But we do know that taking estrogen can increase your risk of breast cancer. Breastfeed if you can, and don't smoke. Smoking really may or may not contribute to breast cancer, but it's important not to smoke because it contributes to a lot of other cancers. Okay? Not necessarily.
Yeah. They want
You said if you had the hormonal treatment, I had it 700 years ago.
Uh-huh.
Does it matter how long you went through it?
Yeah, no, the longer, for women who've had decades and decades of use of hormone therapy and particularly continue it or at increased risk, stopping it can help to drop that risk. Yeah. Yes, ma'am.
What is the chances of having PCOS?
Polycystic ovarian? The chances of having it.
Or getting cancer from if you have that disease?
I don't think polycystic ovarian really increases the risk of breast cancer per se. It may, but I don't remember that being a factor. Yeah. Okay. All right, next slide. So here's one of the most important parts on this slide is know your family history. So a lot of times we don't know who in our family has had breast cancer because sometimes we don't talk about it, right? Aunt so-and-so may have had breast cancer, but you kind of know, oh, she had something, but never talked about it. Or uncle so-and-so may have had prostate cancer, but he never talked about it. It is important for you to know what your family history is to the best of your ability. Who has had what cancer, when, meaning what age, etc., because that can really help you assess your risk if you're at higher risk, something that will trigger you to have genetic screening. Okay, next slide. Okay, early detection's the key. Breast cancer mortality or death rates declined 40% over the past decades. That's why early detection is the key. Next slide. So we went through that. Keep going. Okay, these are slides, and I can get these slides to Dr. Gilliam to share with you all, but these are some of the things that we talked about when I didn't have my slides to cue me. So again, and knowing what's normal for you. I think we talked about all of these. Next. Okay. So many women will ask me, well, do I have to have a mammogram? Can't I just have an ultrasound? Mammogram is the gold standard for screening. It's a screening test, meaning that we don't know that there's something wrong. You're at average risk, and you get a mammogram. That's what you really need to have. Not an ultrasound is the first thing. And for those who put off getting their mammograms because of the pandemic, do not put them off, because we are really seeing we're seeing more people being diagnosed with breast cancer at later stages because people put off their mammograms during the pandemic. It's time to get back into your regular screening. Next slide. So what is a mammogram? So a mammogram is an x-ray of the breast. And basically what happens is you go in, and there's a mammography tech, and she places your breast on a film, a cold tray. Thank you. Yes, it's a cold tray. And then they put another cold tray down that squeezes your breast. Now, there are women who will not go and have the mammogram because they're afraid of pain. Now, for anybody that's had a mammogram, it is not the most pleasant thing, but that discomfort usually lasts about 30 seconds. It seems like 3 hours sometimes. And I constantly think, oh, I know a man invented this. If a woman had invented it, it would have been better. Those are the thoughts that go through my mind. But nevertheless, it can save your life. And they take different views of the breast. If everything is okay, they call you back for your next year, or they'll say, come back next year. It's important to know that if you have something that you suspect is wrong with your breast, please tell them, because they do more views. They do something called a diagnostic x-ray rather than a screening x-ray, and take more views. Also, please know what your mammogram results say. Everybody's supposed to get a letter. If you don't get a letter, ask, where is my letter, and what does it say? Because if there's something that's on there, and somehow they have not let your doctor know, nobody knows to follow up. So we have to be proactive in our health. Okay? I'll talk a little bit about when do you get screened. So it's confusing, right? You hear, oh, this group says you should screen this frequently, this group says you should screen that frequently. I like to follow the American Cancer Society guidelines, which are on the right. So if you're 40 to 45, it's really kind of a personal choice about whether you should get screened. Now, the caveat of that is, if you have a first-degree relative, a mother, a sister, or someone like that that has had breast cancer at a certain age, you need to get screened at least 10 years before. So what do I mean by that? My mother had breast cancer at 43. I had my first screening mammogram at 33, and then I started back at 40 getting my annual mammograms. So if you have someone, particularly a parent that has had a young age of breast cancer, you may need to start earlier. Or if you are deemed to be at high risk because of your family history, your screening may start earlier. Why don't we start to screen in 20-year-olds routinely, et cetera? It's because their breasts tend to be dense, and it's hard to see anything on the x-ray. So generally, some people start screening earlier if they're at high risk, but generally you should begin to start having that discussion with your doctor at age 40. Definitely by 45, you need to have annual mammograms. The American Cancer Society recommends annually 45 to 54. Then up to every 2 years, 55 plus. I still try to have mine annually, every 18 months, 2 years if I've forgotten. And yes, doctors do forget, sorry. Yes.
Here I come, here I come.
I had two, what do you call it, diagnosis, or where they cut in and
Biopsies?
Biopsies.
Mm-hmm.
And each time they said it was some milk duct. Okay. And I noticed that every time I go back, because I'm in my 60s, so I go every year, they put a little, they always ask me,
Yes.
and they put a little tag on it.
Yep.
Are they looking for it to grow back, or they just know that that is not going to be, they don't have to worry about that area anymore?
Yeah. So what radiologists do, and that's a great question, is if you've had prior mammograms, you always want the radiology center to have your prior mammograms to compare. And they will always give you a screening form to fill out. And so you need to keep track of what has happened when, what year you've had your biopsy, and if you know where, so that they know that if I see this on the mammogram, this may or may not be something that is explained by what her history is. And so sometimes people have a scar from a biopsy, so they want to mark the scar so that they know, oh, that's the site of a prior biopsy. But what the radiologist is looking for is any change on the mammogram, which is a film, and I'll show you that in a second. It's a film of the breast, and they are looking for specific changes.
I have a question in regards to the recommended age for screening. So
Yep.
thank you for sharing that. And you mentioned earlier about us advocating for ourselves. A lot of the times I get individuals who reach out to me and say that they're not recommended at that time and that their insurance won't cover for them to get a mammogram. How can women or men advocate for themselves, because regardless of what these guidelines say, their comfort level is knowing today and not waiting until they're 40 or in some cases older?
Yep. So the question is, I think if I take it right, if they are below that recommended age, right? So it depends on how low they are. If they're in their 20s and and they have no specific problems and they have no family history and nothing that would be suggestive of a cancer. So if they have a, so,
Like maybe even their mom or their aunt or
Yep.
even their sister.
so if they have a strong family history, their primary care doctor can actually do a calculation about what their lifetime risk of their breast cancer is. There's something that's available online called an IBIS score, where they plug in who's had breast cancer in your family, at what age, and they can come up with a risk, and that will tell them, the doctor, as to what that risk is, and that can help inform the patient as well about what their true risk is. So the take-home point to that is, if you feel that you need something, you need to really talk to your healthcare provider about why or why not you should not have it. And if you really feel strongly, you can certainly get another opinion from someone. So the question about when to stop screening, the recommendations on the right, or excuse me, on the left say after 75 there's insufficient evidence that suggests that mammograms make a difference. I like what the American Cancer Society says is, you really need to individualize that. So if you're above 75 and above, as long as you're in good health and have a life expectancy of at least 10 years, you can keep getting your mammograms, and probably should. We find cancers in older women. But if you are 75, you have really bad heart disease, really bad diabetes, you have some other thing where your life expectancy is short, then the question would be, if you had your breast cancer, what would they do about it? This is the conversation you have to have with your doctor, right? And it's an individualized. So the takeaway is this: just because you're older doesn't mean you should stop screening, but you should put it in the context of how your overall health is. So next slide. So this gives you an example of what a mammogram looks like. It's an X-ray. It's a lot of gray and white shadows, but the radiologist is looking for something like where the arrow is a little round thing, or they may look at little dots on the screen that's called microcalcifications, which may point to something being wrong. But the radiologist is comparing from one year to the next, or if it's the first mammogram, they're looking to see, does something look wrong? Next. So what happens after a cancer diagnosis? Next. So treatment is based on biology. Remember I said in the very beginning there can be different types of breast cancer. How you're treated is based on the biology, not even so much the stage. We used to just look at how big the tumor was, did it go to the lymph nodes or not, is there spread to vital organs or not, and then we kind of gave everybody the same treatment. Now we know a lot more, that there are different types of breast cancer that merit different types of treatment. Next. So if there's something abnormal, either felt or on the mammogram, a biopsy will be done. The lady over here said she had a biopsy. It can be done with a needle. Usually they don't necessarily do an excision where they take the lump out anymore. It's more commonly done with a needle biopsy. The important thing is that 70 to 80% of biopsies are negative. Right, so this is why it's important, if there's something abnormal, don't freeze, don't say I don't want to know, don't say I'm just going to not do anything about it. Find out what it is, because you may not have a cancer diagnosis, but if you do, you want to get early treatment. Next. Staging means we just try to understand how advanced it is. And so There may be additional imaging given of the breast. We may be doing additional types of x-rays. They may be doing additional whole body x-rays. They're going to sample the lymph nodes as long as it's an invasive cancer and you're under 70 years of age. They'll sample the lymph nodes to tell whether it's spread or not. Next. And this just kind of goes through, and I won't spend a lot of time, but just know that there are a good 5 different types of breast cancer, so breast cancer is not one disease. Next. So treatment can entail one or all of these: surgery, radiation, chemo, hormone therapy, or what we call targeted therapy. So surgery is where they take, and I'll show you some pictures in a second, where they take the cancer out, just take the cancer out with a margin of normal tissue, or they take the whole breast off. Radiation therapy is what I do, is using x-ray therapy or particle therapy for treatment. Chemotherapy is using drugs. Hormone therapy is using pills that block the hormone proteins that sit on the surface of cells that attract estrogen if your tumor is that type. And targeted therapies are therapies that we use in breast cancers, such as what we call HER2 breast cancers or triple-negative breast cancers, and they're not chemo or hormonal therapy. Next. So this goes to the question that you ask. If a patient has a tumor in the breast that when they take it out, it can leave a good cosmetic result in the breast, meaning that the tumor's not so large in comparison with the breast, then patients can have a lumpectomy and save the breast. But sometimes the tumor is large, or if it's what we call inflammatory breast cancer, where it's involving the skin, where a mastectomy has to be done, where the whole breast is taken off. The survival is not different between lumpectomy and mastectomy, and for many women, they're given that choice. Not infrequently, when I see a patient who has a new breast cancer diagnosis, she's just like, take off the breast, take off both of them. And we're like, wait, take a breath. Right, because the initial thought, the fear that comes for many women with breast cancer diagnosis is that I just want the maximum amount of surgery. But the takeaway is that there isn't a difference in survival between lumpectomy and mastectomy. It's a personal choice. And for some women, they don't want their breasts gone. For other women, they feel better having a mastectomy with or without reconstruction. And that is their choice, and we honor their choice. We just want to make sure that they have had time to think about it and it sinks in. Now, there are situations where the surgeon says you need a mastectomy because if I take out the cancer, it's not going to leave you with much of a breast. There's too much in the breast. And so sometimes they don't have a choice, but many times they do. The surgeon's going to sample the lymph nodes, and we can answer questions about that later on. And if a woman has a mastectomy, they may get a reconstruction. Next. So that's the lumpectomy. They're just taking out the cancer and leaving the rest of the tissue. Next. With a mastectomy, they take the whole breast off, sometimes saving the nipple. Next. And with the sentinel lymph node sampling, they inject the dye where the tumor is. It travels to the lymph nodes, which run in the armpit area, and then they make a little incision in there and take out some lymph nodes. Next. So I want to get to this point about clinical trials. So we as black people typically have a distrust whenever we hear the word research because of our history of Tuskegee and all the things that have happened. But the only way that we have gotten to an improvement in breast cancer survival is through research, where we test new treatments, new drugs, new forms of radiation against the current therapies to see are they improving our outcomes. It is vitally important for we as black people to participate in clinical trials so that we are represented, so that we know are things working the same way in us as they do in other populations. So I would at least say that if you're ever in this situation, even if it's not about cancer, but it's about some other disease, at least listen or ask, are there any clinical trials? There are tremendous amounts of safeguards that protect us against anything happening. You know, I've written trials, I've put patients on trials. You do need to understand what the trial is about. But remember, there are very few trials that just are written for black folks, right? So white people, Hispanic people, Asian people are participating in trials. So They're safe, there's safeguards, there's training, there's oversight. Next slide. So this last couple slides, we have an organization, the materials are on the table, Coalition of Blacks Against Breast Cancer. It was started 12 years ago to provide support to Black breast cancer survivors and their families in the Phoenix metro area, and also to do education outreach like this in the community. We meet the third Sunday of every month. During COVID, we went virtual, so we still have a virtual option, but we're back in person at the Cancer Support Community, which is at 7th Street and East Palm Lane. We actually are starting back our CBBC West Valley at Antioch Church of God in Christ in January, and we're looking for an East Valley expansion probably sometime in 2023. But if you know anybody that has breast cancer that could benefit from support of folks, it's great. You know, a lot of times people think a support group is all sad and everybody's sitting around crying, etc. We have a good time, right? And you'll hear from some of our CBBC members. And we also educate during those sessions about breast cancer treatments, about health, about a variety of things. And we have a website, which is on that brochure, which has a lot of information. And the last slide. And we have, sorry about that, that's my glucose monitor going crazy. But we have now started the Coalition of Blacks Against Prostate Cancer. So any of you all who know Black men with prostate cancer, we have started up. So tell them to find us on our website. And for those breast cancer survivors who may want to join us from other parts of the country, because we're virtual, they can come too. So we have people from all across the country. So that's all I have for now. I'll be happy to answer questions later on, but there you go.
She thought she couldn't do 45 minutes. Thank you. Actually, don't sit down. If you could join the stage, if you could go on the stage, and we have, I'll let them introduce themselves. I literally asked her to send me a bio, and I took a screenshot of it, and I left it over there, and I'm on IG Live. So we'll invite up our panelists. Am I saying your last name right? Mr. and Mrs. Clicquot. French and fancy. I love that. Kevin, are we able to bring the lights up on the, oh, he's already ahead. I don't even know why I asked him. He is like AV extraordinaire. So each one of our panelists, well, with the exception of Dr. Halyard, are going to just give themselves, give a brief introduction of themselves, and then this will give us an opportunity to ask questions of the panelists so that you leave here today more than informed, so that you can take the information, the knowledge that you gathered today, and share it with family and friends. Okay, and if you wouldn't mind introducing yourself to the group.
My name is Carl Clicquot. I'm Charla's husband. I would say a few things on my resume, but it's extensive. It takes too much time. So I'm a retired military, and I'm retired, and I'm Charla's husband.
That's important.
So, I'm Charla. I am a 7-year breast cancer Can you hear me now? Yes. Oh, wow. Okay. I had HER2 positive, and Dr. Halyard talked about that a little bit. My cancer was a stage 3 plus, and that was in, I'm 57 now. So I was about to turn 49 when I got my cancer diagnosis in 2014. A couple of years prior to that, in 2009, I had a biopsy. the type Dr. Halyard talked about, where what they saw, I had already been getting my mammograms, but this particular time they saw something different on my left breast, and so they wanted to biopsy. It was close to muscle, so I ended up having to have a like a little surgery to do the biopsy. So that left a scar. So she spoke to that too, about the markers. So I have that scar now. A couple of years beyond that, I had another issue on the left side, and had a different type of biopsy then. I had the needle biopsy. They kind of lay you down flat on a table, and your breast comes through the bottom of the table, and they do the biopsy and gather the cells for the sampling. Both of those biopsies were benign, and a couple of years beyond that is when, because of the, let me kind of backtrack a little bit, because of the first biopsy that I had a lot of scar tissue in that breast, and I started noticing one, I'm perimenopausal during that time. So I was having a lot of little changes with my cycle, and being your own advocate and being your best advocate is so important, because you have to really know your breast. And I was doing all of those things. I was getting my mammograms regularly. I was, doing my self-exams. I'm paying attention to my body, trying to do right and be right by it. And I started noticing that my left breast was tender. So then I start like, okay, is it my posture? Is it the way I'm sitting when I'm driving? Is it the way I'm sleeping? So I started trying to eliminate a bunch of different factors that may have been causing me this discomfort in the left breast. I eventually got a mammogram. It was time for my mammogram, and I had told my GYN like something is wrong with this left breast. I noticed that it was different from the right side when it was time for my cycle. So when I went and talked with my GYN, she was like, well, yeah, she did the whole exam like they're supposed to do when you have that annual exam that we all hate. Okay, we all hate it. But she didn't feel anything, and it was then time for my mammogram, and they didn't find anything on the left side, but what they did find this particular time is something on the right side where they hadn't, I hadn't had any history of any, abnormal spots, I guess. So that was concerning. I did mammogram, then they did more film with, they did like so much film that day. Plus they did an ultrasound because, again, I had two occurrences, sort of, on the left side, but nothing in the 9 years I have been getting mammograms on the right. So as it turns out, the right side was DCIS, ductal carcinoma in situ. So a precancer, but I had 3 spots, and my breasts weren't that big. So for me to get a lumpectomy would not have given me a good physical return. How would I say that? Yeah, cosmetic return. Because they weren't close and would have had to get the good margins and all that jazz. So when I saw my breast surgeon to have this conversation, And my primary care doctor told me, you know, if you've got to get breast cancer, that's the best type to get, if there's a best type. But, you know, when you hear that word cancer, you don't think, okay, how can it be like a good type? But the survival rate is very high because it's more of a pre-cancer. So when I went to see the surgeon, I again told her I was first meeting her, but I told her about the left side and how I was having this pain. My radiologist said breast cancer isn't associated with pain. They didn't see anything going on with my left breast, and I had to keep telling people, like, something's happening here. I know my body. So the surgeon, she has to do a biopsy right there in her office, and a couple of days later, my survival rate significantly was reduced. I just remember, like, telling Carl, he was with me when they gave me the results for the right side, and we thought, okay, it's not going to be terrible. The survival rate is very high. But when I got that second diagnosis on my left side, because the left side was riddled with cancer, and Dr. Halyard talked about how our breasts can be really dense, especially women of color. And then I had all this scar tissue. They couldn't see during the mammograms any of the cancer. And I'm telling you, it was full. So the diagnosis and the treatment went very quickly. I ended up having 6 months of chemo, followed by a bilateral mastectomy, and then I had radiation. So, but after my second treatment, I found CBBC, back then the Coalition of Blacks Against Breast Cancer, and they were a godsend. Like, they welcomed us. I came in with a bald head, and, you know, I didn't know anyone that looked like me that had breast cancer. So to find this group and for them to welcome us and just treat us like family, we learned so much. We got so much support from the group, and we're still, like, loving on them every chance we get, because the meetings are informative. All the survivors, the supporters, the just advocates, the education that we get from the group. You can't do this alone. I mean, some people may have to, or in some respect, but you don't have to. You have to find a support group, whether that's, you know, your girlfriends, but if you can, or, you know, coworkers, someone, you have to have a support group. And this is what CBBC provided. He's telling me, like, shut up, you need to be quiet and wrap it up. Oh, does anyone have any questions for me? No. Okay.
I do. How
Oh,
long
you
ago
do?
was this? How
Pardon me?
long ago have you been a survivor?
7 years
7
now.
years. Oh, wow.
Yeah. Thank you.
I have a question for you also. You mentioned something about having to have a different type of biopsy because it was closer to muscle. Can you explain, well,
Maybe Dr.
maybe,
Howard.
yeah, I was going to say, can you explain why that is, if it's closer to muscle?
You know, I don't know about Charla's particular case, but sometimes they have to go more deeply in. If they can't necessarily see it on imaging, perhaps they did an excision. So it doesn't, being close to the muscle in and of itself doesn't make you necessarily have to have an incision, but it just, the radiologist and the surgeon really determine how best they can get it. Is it by x-ray or is it by surgery? And the other thing that she talked about, which I think is important for takeaway, is that she knew something was still wrong with her breast. And although 90% of breast cancers are picked up by mammogram, there are some that are not. And so sometimes additional or different imaging needs to be used in addition to the mammogram, which may not show it, such as an ultrasound or an MRI. There are certain cancer types, like what we call invasive lobular breast cancer, which starts in the milk sacs rather than the milk ducts, which may not show up as well on mammogram. And so the takeaway point is if you feel that there's still something wrong in the breast, keep pushing until you get an answer.
What do you think about wired bras?
There is no data that suggests that underwire bras cause cancer, nor is there any data that suggests that antiperspirants cause cancer. You know, there are a lot of myths that are out there, and that's one of them.
Thank you very much for sharing, first of all. Did you have to have any kind of mastectomy or anything like that done? And if so, what kind of emotion, stress-wise, did it put in your life, and also for your husband if you did?
Yeah, I chose that. It wasn't something that I thought about a whole lot. I knew it was what I wanted to do. At this point, now we've been married 34 years. We have 3 kids. He had plenty of time with them. I nursed 3 kids, so I did get what's called expanders. So when they did my mastectomy, they put in kind of like like a breast implant, and they fill it with saline. Basically, so if you have radiation and the skin is going to contract, get tighter, they do the expanders so that you have a bigger pocket if you wanted to have reconstructive surgery. The problem with, I had those, they were extremely painful, but by the time I got finished with my radiation, and your body is still radiating a little bit, so you expect a little bit of blistering maybe, or some changes in the skin. But what was happening was my skin on my right breast started dying. It was disgusting. Basically, it was really bad, and they told me, well, you just finished radiation, so you're going to see some changes. But my skin we could see the implant, like the little mesh. And so I had to have an emergency surgery. My reconstructive surgeon told me that we could keep the left side, but I said, no, I don't want to. Just take the other implant out, and we're good. And the challenge with that is just trying to find clothes. Everything has darts. I never really cared to wear a bra. I wore them, but as soon as I got in my car, leaving work, it was in the back seat. Like, I hated wearing a bra, so I knew that like a prosthesis wasn't going to be for me. So that's not something that I chose. So you wonder, like, when my head was bald, are they staring at me because they know that I'm sick, or they wonder why I cut my hair this way, or why don't I have hair? Same thing when, they look at me, or people look at me and they see that my, I don't have any breasts. It's challenging. It kind of, it can make you down, and I've had some therapy. People, I think you need therapy. It's something that has helped me along the way, not just with, or not just the therapy that I have with my support group, but when I'm.
Well, the part that's important, right? Using a body part,
You know, and I'm gonna speak from the male perspective on this. So, you know, males, right, we start out with the breast as kids. That's where we learn, you know, the female body. So that's where we go at. You know, so for me, right, I gotta think I have to think about this like, okay, yes, she asked me about how I would feel. Okay. But I had to think before I said anything. And so all I said was, you know, I'll back you on whatever your decision is. Because now we're talking about, I could possibly say the wrong thing, which could be selfish. So now, don't get me wrong, I had selfish thoughts, yes. Because I didn't realize that it would affect me the way it would. Because, you know, I've been with her since we were 15 and 16 years old. I didn't start with her breast at that age. But, you know, I was older, but, you know, it was almost, you know, when I thought about it and being at CBB AC, I thought about it, and I was like, it was almost like losing two friends. Okay, in my mind, that's how it was. It was like losing two friends because we've been together for so long. You know, so I had to think about this. You know, and then I also thought when this happens, you know, I wanted to be the one to take the bandages off, so I had to prepare myself. You know, so I asked questions in the meetings, you know, with Michele. Then I looked at pictures. I also looked at pictures of women who had mastectomies. So that way, my expression would be the same as taking a bra off. You know, I was as close as I could get to that as possible. You know, because again, I know that this is affecting her. You know, she may not be showing it outwardly, but it's body parts. You know, so I have to do my part. And again, in her situation, she was fortunate because we've been together for so long. But then we have friends that they're not in that situation. So it's something to think about, you know, if you're not with someone, how is that going to go? You know, in that situation as a man looking and thinking, you know, because today in today's society, that's all we talk is visual. It's visual. You know, you see the person, but then when you get home, it's like people start taking off the clothes and, you know, everything else. And it's like, okay, well, now how are you going to act in that situation? So I had to think about that, and then I just had to start over. You know, I had to start over and say, okay, this really affects your, you know, you as a person. Not necessarily the relationship. It affects how you act in the relationship. You know, from a man's perspective. You know, so how am I going to act? What am I going to do? So I got to, you know, ask more questions and that type of thing. And I have to stay in tune, right? And this is why, you know, the support group is good. You know, and again, I had an advantage. You know, when she was diagnosed, I was 50. You know, I've spent 26 years in the military, so I don't panic. You know, my training, all that kicks in, tactics and all this operational stuff. I need to do stuff. You know, of course, I was in a fog when I heard the word cancer because when she said it, I just went with it because, you know, we go everywhere together. But I knew something was up when they called me back in the office. I immediately knew that, okay, I ain't never been called back here. So I knew that something was going on. And so once I came out of the fog, you know, I had to get, you know, I had to say, okay, then I went into, you know, operations. I need to, you know, get answers. And the first thing I realized was, dang, I can't lead from the front on this. I got to find somebody who can give me information. You know, and this is how we came about, you know, finding Michele, because what I did was, you know, I started doing research. You know, I've been to college a couple times. You know, I know research. So I'm researching for hours, and all I did was create more questions, which had me looking for more answers. And I realized I need to cut this out because it's not effective. So I found experts in the field that could answer all my questions. And I could find out who's got the right technology, who are the doctors, and all these types of things. Was that a hand for a question?
Okay, doctor, my mother had breast cancer, and they removed one breast, and everything was all right. 6 years later, then the other side. The thing is, she had the surgery, they removed it, but then they sent her home when she came to our home, and it was an open chest cavity, and they had me treat her with saline like twice a day. And it didn't sound normal to me because I was more fearful because, one, I wasn't a doctor, and then two, is this going to be a problem? It turned out to be all right, but I didn't know what kind of practice this is. This something new, or is this something to look out for? Because, I mean, she was in the hospital for about, 6 days, came home, it was open, and they just had me treat her with the saline twice a day.
And how long ago was it?
Okay. That was the early part of the 90s.
Yeah. So things have changed a lot. You know, so when my mother had her breast cancer when I was, 5 decades and decades and decades and decades ago, people stayed in the hospital she stayed in for 2 weeks. Now they send you out like the same day. So things have changed. So it's really unusual once a person has a mastectomy these days for the skin not to be closed or for a flap not to be given over top where they put skin if they can't close it for some reason. So I don't know the specifics of why it was left open and left to kind of heal on its own. But that usually isn't what happens today. So, we learn more and more along the way. We learn more and more with each year, with each decade about how to treat patients. But unless she had something where there was so much disease that they couldn't close it, but generally in that particular case it would never heal if there was active cancer. So I don't have a real good answer for you. But all I can say is for mastectomies these days, the skin is sewn shut, and so you don't have kind of an open area generally that people are sent home with. I think there's a question over here. Oh.
Yes, I have a question for Charla and Carl. At the time you were diagnosed and you said you were 49, how old were your children? I know you have some daughters. And just want to know the whole family dynamic around talking about what you were going through.
Okay, well, when she got diagnosed, right, it's kind of funny, but, well, it's not funny, but it is, I was going to start a new career on a Monday. She got diagnosed on Friday. I drove, and then I told him I can't take the position, right? So then we didn't tell anyone for 3 months because I knew immediately that people ask questions. I got to talk to her mom, her dad, her sisters, my parents, my sisters. I got to talk to everybody, and so I know they're going to want answers. So, it took about 3 months for us to, get enough information to be comfortable enough to go ahead and tell them. Now, the kids were, youngest one still in high school. The older two were out. They were getting ready to start their careers. So what I did was I simply just, sat the kids down and told them, that this is our life. This is our situation. No one's going to they're not going to use their mother situation as an excuse to not graduate from high school, not go off to the military, or whatever they're going to do. And there are 3 different personalities, so I told them that. Of course, nobody really had anything to say at that time because they needed time to process. And, I just checked on them as time went on. I just checked on them, hey, what's going on, because I know who they are and how they are. Son doesn't talk very much. Middle one a little bit. The youngest one cries a lot. That type of thing. So we just paid attention, and again, to each other, we just kept, have to ask questions, how you feel in that type of thing. And again, that goes back to the support, having support, finding support, and getting answers, being as prepared as possible as you can be, because it's not fun and it's scary, and especially for me, because again, at the point I was after 26 years in the military, it's like there's a lot of things that I can handle. At least I felt like I could handle everything, and then I get a situation that is an actual challenge that I can't necessarily handle. So I have to be smart enough and intelligent enough to get help. The same, unfortunately for me, I'm organized. I keep copies of everything. I ask a lot of questions. All these things. I think we only had to get rid of one doctor. Because he just wasn't cool. She wasn't comfortable with it. It was very important. If the person, and I'm a good judge of character, and I can tell as soon as he started talking, okay, man, you can't come in here no more. But you have to do that because otherwise, it kills spirit. And this is what keeps a person motivated to endure the situation. So you have to be very aware of that. And it worked out for everybody. Her breast doctor was a female. She's very comfortable with her. The oncologist, female, very comfortable with her. I think we only had one person, our radiologist. And I asked him. He was young. He looked like he was fresh out of college. But I asked him. He was up on all the new technology because I had already talked to Michele and I found out who's using what, and what they were using at Mayo, they were using at Palo Verde. So I said things were fine. And same thing, I was over at Cancer Centers of America. I did want to burn that place down, but because they didn't want to take the insurance, so I was about to burn that place down. I was like, oh, but I got past that. And asked some more questions, and it worked out. But you definitely have to find a resource. I'm an unpaid plug. Coalition of Blacks Against Breast Cancer had all the answers I needed, and the resources, and people who truly care, and that's key, because some people, I never heard the word terminal. I listened for that closely. I didn't pay attention to the numbers because numbers mean, okay, we can still have some success. And again, this is because of my background. I'm looking at certain things. If it's over, it's over, but I never heard that. So then, okay, we can still organize. We can still endure this because they didn't say that. Nobody said it. So you can't necessarily buy it. I mean, perfect example, my daughter went into a class in the military, only a 25% success rate. 75% of the people flunk out. And it's male-dominated. And I told her, I said, look, you're going to be in the 25%. Don't worry about the larger number. And that was the same thing in her situation. I said, look, man, that number not zero. The number you got is not zero. So that means that, you could be motivated.
Hi, thanks for taking the question. So this actually is for you, Dr. Halyard, right? You mentioned earlier that there was a way for you to find out kind of like a pre-screen, if you will, for genetically if you have cancer in your genes, correct? Am I saying that right?
So there's a calculator online that your doctor can do called an IBSS that basically shows you whether you have an increased risk beyond an average risk of developing breast cancer. And then that can tell you whether you may need enhanced screening, more frequent screening, or screening with a mammogram and an MRI. However, if your family history suggests that you may have a genetic defect that puts you at increased risk of having breast cancer, like a BRCA1 or 2 gene or some of the other genes, then basically what they do is they test blood or saliva, and then that basically, they run an 84 gene panel, and that actually can tell you if you have the gene or not. We do have a trial going on at Mayo for genetic testing for people who may be at high risk. We've also done trials or studies for people with family members who have had cancer to test their genes. So there are different ways of being able to get genetic testing.
There was a couple of things that came up that I wanted to question. First of all, you had mentioned that you had the 2 biopsies and the 2 different kind of tests. And I'm thinking that I've had both of my biopsies were surgical, where I have the scars. So I figure it must be aged, because I know I'm older than you are. So I'm figuring that that's probably why they did it that way on me. It could be that, because you mentioned muscle, because I used to be a bodybuilder. maybe I had muscle and that's why they did it. And so that kind of cleared up something for me. But I was, your husband mentioned about, I was always curious to know when a man is really aggressive with our breasts, could that cause breast cancer?
No, you don't get breast cancer from trauma. So that doesn't cause breast cancer. And the issue about an incisional biopsy versus a needle biopsy, over time, we have learned what kind of biopsies can be effective. So decades ago, they were doing a lot more excisional biopsies where they made an incision versus a core biopsy where they needle it. So there are some times when you actually need to go in and do an excisional biopsy or an open incision these days, but much more frequently we're doing needle biopsies. So it's kind of like that again, we do research over time, we find out what works better and just kind of migrate that way.
The other thing is I know that I think because have been a bodybuilder, that my breasts don't slink, but a lot of women's breasts start slinking. You know what I mean? And sagging.
I knew what she meant.
Okay. And so when that happens, you can kind of, I'm now almost, I got 2 more years before 70, so I'm starting to feel these little difference that you're saying, where my breast is starting to fall. That's been my best feature, so I noticed that right away. And so when that happens, is that something we need to really worry about, or like she was saying, is it age that we?
Well, if it's something you're really concerned about, your primary care doctor or your gynecologist can do a breast exam. If you have a particular area that you're concerned about, when you go and get your mammogram, they can mark that area to see if they feel anything or see if they see anything. But a good way to also look is to see, is it changing over time, right? Is this normal for you? Although there can be cancers that you can feel that stay stable for a long period of time, but if something dramatically changes, it gets bigger, you have pain there, skin changes, et cetera, that's something to be checked out as well.
I had last Sunday a wired bra. Didn't know till I got home that my breast was bruised because of it. I went ahead and had a mammogram done. And when she did that, the part that I'm talking about wasn't in that. You know how they put you in there. So I felt that since that part wasn't in the film, I don't think,
The radiologists look at the film before and determine whether, when they step out and then they come back and tell you can go. Part of it's the radiologists are looking to make sure that they've gotten all of the breast tissue down to the chest wall and that it's a good film. So likely they did get it because they typically go from up here down. So you know how that thing just kind of squeezes in the down. So they typically do, but in breast centers they're actually looking to make sure that they're seeing all that they should be seeing.
Thank you. You guys are wonderful.
So we're going to take one last question. Okay, 2 last questions so that we can wrap it up. And if I'm paraphrasing this wrong, Charla, you mentioned about being told that breast cancer doesn't have pain. And you personally said that that's not the case. I believe that's what you said. And then secondly, another, something else you mentioned about the implants. So does implants potentially increase your chances of having breast cancer or hiding breast cancer cells? Did I ask the question about the pain rate? I'm not sure.
When you go in for your mammogram and they ask you different questions, are you feeling any pain or anything like that? And if you tell them yes, then actually someone shared with me, well, there shouldn't be any pain because breast cancer doesn't have any pain.
So generally breast cancer doesn't hurt, but it can, right? So there are people, like Charla said, she felt discomfort, so it can be painful. but the absence of pain does not mean that something isn't cancer.
I think that is because I was feeling so much discomfort on that left side. That's why I kept pushing. I knew that it was just something was wrong. It wasn't normal. And then additionally, in regards to like the implant, I didn't have implants prior to my cancer diagnosis. I got the implant once I had the mastectomy in an effort to make a pocket post-radiation for reconstruction. Okay, so, but like Dr. Halyard said, I don't think that there's any reason.
So to answer Dr. Gilliam's question, there's a small percentage chance of developing a certain type of lymphoma, which is a cancer of the lymph glands within the breast that's associated with cosmetic implants or implants that are placed either for cosmetic augmentation or post-mastectomy. It's the kind of breast cancer that we've been talking about, invasive ductal, invasive lobular, precancer, is not associated with implants, but there is a type of lymphoma that involves, there's just a cancer that can be associated with implants.
My question's kind of simple, but you always talk about the 5-year survival rate. Is there any reason why we picked 5 years as opposed to 10 years?
Yeah, it's just an arbitrary time point that doctors report stuff, but we report stuff at 10 years, 15 years, 20 years, etc. But for most cancers, at least for triple-negative breast cancers and HER2 positive, which are two subtypes, if you're out 5 years and you haven't had a recurrence, essentially you're cured of your cancer. The cancers that are estrogen and progesterone receptor positive without these other markers, they can have a later relapse, a later time to come back, even decades later. But that's just kind of an arbitrary time point that we pick to report data.
Okay, I did have a question. I've heard that once you have cancer, it lays dormant and then it will reoccur. Is that correct?
No, there are some people that are cured forever of their cancer. It kind of goes with what I was saying to her with like different types of breast cancer. So there's certain types of breast cancer that once you get about 5 years out, it's not coming back. You may develop a different type of a cancer, but it's not coming back. But there are certain types of breast cancers that can have a long latency period, meaning from time of diagnosis to time of recurrence can actually be a longer period of time, 10 years, 15 years. Sometimes we see 20-year recurrences. Just depends on the type of cancer. But it doesn't mean that when we talk about cure rate, and when I say 80% of people are alive and well at 5 years, that really translates into cure rate.
Oh my goodness. I don't know if everybody else like me feels blessed to have had this conversation and this event today. I want to thank our panelists. I want to thank the Mayo Clinic. I also want to thank the Coalition of Blacks Against Cancer and the Coalition. Are you going both names or just one?
Yeah, so we've created a new umbrella organization to expand the number of cancers we tackle. So we were Coalition of Blacks Against Breast Cancer for 12 years. We still are. Mm-hmm. We've created Coalition of Blacks Against Cancer as an umbrella organization, and now we're focusing on prostate. And once we get that down, we'll keep moving on because there are a lot of cancers that affect Black people.
Yes. You will also see on your table, please grab one. If you're interested in becoming part of the Coalition of Blacks Against Cancer, please fill this out. Also, I believe on your website you can actually submit information of interest online, but the information that you need is on that sheet. You'll also find on your table a little more information, which will give you the Facebook page, the Instagram page, so you can like or follow. I please highly recommend that you like and follow this organization. Lastly, you heard the conversation behind clinical trials, and you've heard me talk about clinical trials. This is so important. Now, clinical trials that might be available today might not be individuals who have no breast cancer, but there might be some. There's some. Okay. So And somebody in this audience, I cannot remember, but someone called or texted me to say something. They wanted to know more about clinical trials at Mayo. If you're not in here and you're online or you're on Instagram, now you know how to find out more. And we're going to finish. Denise, you have a question?
What you shared, there's information out in the table on prostate cancer, our Coalition of Blacks Against Prostate Cancer, as well as an information sheet regarding prostate cancer. So please take those and share those with the men in your lives. And yeah, that was the main thing I wanted to make sure. Oh, in terms of study, the Mayo Clinic study on colorectal cancer. And we have been here at the church on a couple occasions. That study is still open, and there's a flyer there also. And everything's real virtual nowadays. You can take a picture of that QR code and actually see if you're eligible and be able to sign up, and Mayo Clinic will get back to you. Thanks.
And then with that being said, a round of applause for our panelists. And also thank the Coalition of Blacks Against Cancer for your lunch today. They sponsored our lunch. Thank you, thank you, thank you. And Deaconess Gail made a suggestion if we could all come to the stage and take a picture with our panelists. And who knows, maybe they might want to put us on their Facebook page. Thank you all. Thank you so much.